Andy, my thanks as well for a wonderful presentation, and I hope you can stay with us for the rest of the meeting. Our next session is on exploring safe caffeine exposure levels, and we have with us today Mark Feeley, who is with Health Canada, who is going to be the moderator for this session. If you could come forward. And we very much appreciate that you can be with us today, and not only to moderate, but also perhaps to provide a little bit of perspective in terms of Canada. I'd also invite the other two, the panel members, Christina Chambers and Steve Lipschultz, to come up. You've been introduced before to this audience, and since it's a short session and to save time, perhaps you don't have to reintroduce them. But welcome.
Thank you, Dr. Goldman. First of all, I'd like to, as with the previous speakers, acknowledge the tremendous effort that the IOM and the Planning Committee have made to developing this agenda, which is, has been very interesting for the past day and a half in very short order of time. And I'd also like to not only acknowledge but thank our sponsors for this meeting, which should be recognized as the Food and Drug Administration. Certainly, Health Canada has many areas of cooperation that we're currently involved with FDA, and one of them is the overall caffeine issue. In speaking with the Planning Committee meetings, this will be very brief, and considering the topic of this particular panel is exploring safe caffeine exposure levels for, say, potentially vulnerable populations. The Planning Committee meeting, or Planning Committee, had suggested it might be a good idea to give a brief overview of current position with respect to caffeine in Canada. So essentially, we're not overly different than the FDA position. Caffeine, at least when directly added to a food, is regulated as a food additive. So essentially, there is applications have to be made to our department, and a standard safety assessment applied, and then approvals will be granted on a case-by-case basis. Historically, the use of caffeine, at least directly added in food, has been restricted to carbonated soft drinks, initially cola-type beverages, and then it was recently expanded based on an application or from industry back in the mid-2000s to include all carbonated soft drinks. So theoretically, if you're directly adding caffeine to a food for sale in Canada, it's restricted to carbonated soft drinks. I won't really discuss the energy drinks because it's a little bit, let's say, in flux currently, but currently the majority of energy drinks that are on the market in the U.S. Also have market access in Canada with some maybe slight modifications to their composition. Subsequent to receiving the application to extend the use of caffeine as directly added as a food additive to all carbonated soft drinks, Health Canada undertook a relatively extensive scientific evaluation back about 10 years ago. And it was during this, as the outcome of that evaluation, some of the points that have been mentioned in previous presentations yesterday, we reiterated the position that it was unlikely that up to 400 milligrams of caffeine on a daily basis for the general population would be associated with any adverse health effects. So generally, the standard position we had before was approximately 400 milligrams a day appeared to be, sort of a no AEL or a no risk level if we want to get into specific risk assessment terminology. Subsequent to that review in the available studies at the time, we had also identified what we considered to be potentially two sensitive subpopulations. And these were women of reproductive age, and essentially what we showed in the literature review was that there could be, once again, what we see in previous speakers have defined is that there isn't a clear delineation of a cause-effect relationship, and the majority of these studies that were looking at either reproductive or developmental outcome in women relied on coffee consumption as a surrogate for caffeine exposure. So essentially, and I mean, I won't go into any details of these studies. There's the the Oak Ridge National Laboratory review, very extensive evaluation that was conducted at the request of FDA that the IOM committee made available prior to the meeting. Majority of them are described. And in fact, it's consistent with our interpretation of the studies at the time that approximately 20% of the reviewed studies actually showed no effect. So, but we did take the position that it appeared that in terms of fertility indices or fetal development, there appeared to be some associations. So at that time, we thought it prudent to suggest limiting the caffeine intake to that segment of the population to no more than 300 milligrams a day. So that was the one subset. The second subset was children. And essentially, the majority of the evidence that we reviewed dealt with children between the 7 to 12-year-old categories. And certainly, as the previous speaker has described, when an exposure was to pure caffeine in these studies. So essentially, the kids were brought into a clinical setting and provided with a defined caffeine dose as titrated through a beverage exposure. So what the end result of this was that there was beneficial effects observed, and the doses that were used in these clinical settings were starting at 2.5 mg per kg per day and going up to about 10 milligram per kilogram body weight per day. So definitely the similar types of positive effects were seen in terms of task and motor activity and attention, etc. So there was definitely positive effects, but also the authors of some of these studies also looked at what they perceived to be potential negative impacts of those doses of caffeine, and one that seemed to come out not only consistently but at the lowest dose level was both subjective and objective measurements of anxiety in the children. So the children were describing as to be either in an anxious or anxiety-prone state following exposure to the caffeine dose. So based on that research, albeit limited, Health Canada had decided it would be prudent to limit caffeine intake to that segment of the population, so these are children up to the age of 12, to no more than 2.5 milligram per kilogram body weight per day. And you can, obviously that's going to vary based on body weight. And when we've looked at our dietary intake pattern in Canada, it's not overly different than the US, possibly a little different, or a little lower, so to speak. And none of the medians in the population come close to these values, either the 300 milligram for women of reproductive age or the 2.5 mg per kg per day for the children. It's only when you start to exceed the 90th percentile in children and actually greater than the 90th percentile in women of reproductive age where you start to see some exceedances. So we're exploring options in terms of labeling for products and consumer education to hopefully control the intakes of caffeine below these recommended daily intakes. So, and as I said, it was a very detailed summary report on the state of the caffeine literature that was produced by the Oak Ridge National Laboratory contractor for FDA. So I mean, and a lot of these studies, especially a very elegant comparison of all the evidence for these anxiety-like symptoms and effects in children are described, along with comparison to various what they perceive to be no effect levels or low effect levels. So, and once again, we won't really get into the discussion of caffeinated energy drinks, but we have sort of the same situation as it is in the U.S. Sort of as an introduction with the two speakers on the panel, what I'd like to do is try to bring us back to some of the charges that FDA has asked at the beginning of the workshop, and namely, is there specific subpopulations at risk that can be defined? And these are from either acute or chronic exposures to caffeine. So that's one of the main questions I think we'd like to see some sort of answer to. The second one was, is there additional variables beyond individual caffeine sensitivity that should be considered in these subpopulations that defines them as being overly sensitive? And the third point I'd like to raise, which is just an add-on to what FDA had actually asked, was really, as a start, what is considered to be the most relevant endpoints to assist in defining these sensitive subpopulations? we've heard a lot about cardiovascular effects and sudden cardiac death, blood pressure, heart rate. There's behavioral changes. Is there issues revolving around, say, reproductive effects? Are these critical in terms of defining exactly what endpoints we consider at this point, or is the evidence sufficient to define what endpoints we consider that would delineate sensitive subpopulations? So at this point, I'd like to I think invite our both Christina Chambers and Steve Lipschultz to provide some of their interpretation on what they consider as defining either sensitive subpopulations or safe caffeine exposure levels for these vulnerable populations. Sure.